All right. Hello, good afternoon, everybody, and welcome to the October Optimizing Newborn Nutrition webinar, Counseling Parents on Human Milk Substitutes. I have a couple of updates for you all before we get into our educational portion. I want you all to save the date. We have our date scheduled for our annual meeting for GaPQC. It is scheduled for April 25th and 26th. It's going to be at the Emory Conference Center. We hope to see representation from all participating hospitals, and we will have more information to come. But go ahead. There should have been a save the date sent out. If you do not have that on your calendar, go ahead and block it. We'd love to see you there. Also wanted to share about an EPIC breastfeeding opportunity. It's a webinar co-presented with the Georgia Breastfeeding Coalition, Beyond the Pump and Dump Medications, Vaccines, and Use of Human Milk. That'll be on Wednesday, October 25th. We will put the link to register in the chat. It'll also go out in the email following this webinar, but please take advantage of this opportunity to attend that webinar. Dr. Fairley, who you'll be hearing from today, will also be leading that webinar. And speaking of Dr. Fairley, as our faculty today, along with Beth Oppenheim, I wanted to hand it over to Claire Eden to introduce our speakers and then hear from them. So Claire.
Yeah, good afternoon, everyone. I'm very happy to introduce our faculty for today's webinar. Taryn Fairley, as many of you know, practices general pediatrics and breastfeeding medicine at Kaiser Permanente. She's a member of the Academy of Breastfeeding Medicine and adjunct faculty at the Emory School of Medicine. And she currently serves as the physician chair of the EPIC breastfeeding program and our breastfeeding committee at the Georgia chapter AAP. And she's on the GaPQC neonatal committee and serves as subject matter expert for this initiative, Optimizing Newborn Nutrition. Beth Farrell Oppenheim is a nurse practitioner for Mednax working in the newborn nursery. She also works as a lactation consultant at Children's Healthcare of Atlanta Eggleston campus and as a clinical instructor for the Emory University School of Nursing. She's also an educational consultant for the Georgia chapter AAP, and you may recognize her voice from several micro lessons she's prepared and recorded as part of this initiative. I'm going to share my screen so we can get here and play the slideshow. And we'll get here and I'll hand it off to Dr. Fairley.
Hi, great to see everyone. I think everyone's probably sick of seeing my face, but thankfully I've got Beth here to kind of liven up today's webinar, which is going to focus on, just a couple of big things. We are talking about counseling on human milk substitutes with families, but lest anyone worry that we're talking about how they shouldn't use human milk substitutes. That's really not the subject matter for today's talk. I think that might be a little bit, the title might be a little bit triggering, Beth. I probably should have rethought that. What we're really here to talk about is hygiene, adequate nutrition, and cue-based feeding, because that matters for kids who aren't breastfeeding too. Next slide. Yeah, so there also might be some confusion in that both Beth and I are lactation consultants. And that I think most people think of this as a covert breastfeeding initiative, right? Well, yes, but no, all at the same time, right? So like something like 17 or 18% of our families actually don't initiate breastfeeding, right, here in Georgia. And then after delivery, all of this, this is clearly not what we want for our families, right? We want them to meet their goals. But regardless, like the facts of the matter are that a lot of people transition to formula only pretty quickly after delivery. And by 2 months, that's dropped off even more so. And given how access to care is in our state, especially, once we get outside the metro and even within the metro, we really do need to cover how formula or human milk substitutes are given, prepared, their optimal use in the hospital setting. They're a captive audience, people. It's time to teach. Next slide. So for people who thought we're doing great, this is actually our report card. I think we've shown this several times. People are probably sick of this slide, but I think it's good to hammer home that like between the hospital stay, which we still only have like 82, 83% of people who ever breastfed, and that is very much the birth certificate definition, right? Like that is infant to breast to feed one time. That's still 83% of people. So there's, like I said, there's that substantial fraction. And then we do really drop to 53% at 6 months. And then exclusive breastfeeding through 3 months is only 40%. So formula becomes a lived reality for a lot of the families that you're seeing in the hospital, regardless of how breastfeeding is going. And we know that a lot of people are doing mixed feeding during the hospital stay. Next slide. And then, of course, you know, things are very different in our different counties, right? We look down in Southwest Georgia and people are initiating at far, far, far lower numbers. So we really would be remiss to not cover this in this initiative. There is some subject matter to teach. Next slide. And so, yeah, there's actually some guidance on this from WHO and Baby Friendly Hospital Initiative, right? So this is Baby Friendly Hospital Initiative, something we haven't talked about pretty deliberately here during this initiative, because that is not what this initiative is about, but it is an important compendium of evidence on maternity practices to promote breastfeeding. And they specify pretty plainly in their guidance, in order to designate as a baby-friendly institution or to certify, they have to teach about infant formula. So some others who are feeding breast milk substitutes by necessity or choice must be taught about safe preparation and storage of formula and how to respond adequately to child's feeding cues. This seems interesting. No? Anyone else? Like that this is so explicitly stated in Baby Friendly. So why is that? Next slide. Why do they care about this? This is why. Because otherwise, if we don't talk about what is involved in infant feeding on the other side, on the non-breastfeeding side of things, we are setting up a very false narrative for families. So for the tearful mother who's having difficulty latching in the hospital, who's in a lot of pain, who's struggling and having to have help with every feed, it seems quite easy to grab the 6-pack that's at the bedside, right? Slap on a nipple and just feed an infant. Because that's what we have, right? That's what's provided for people who don't hold their own formula contract, who don't pay fair market price for formula. That's what you have is our things that are provided for relatively low prices to the hospital in which you work. And they're just kind of doled out everywhere. It's ready to feed. It's you uncap it and go. But that's not really what it takes to formula feed for those who've done it, right? As you progress along in your journey, that's not what most people do. For one, this is pretty much liquid gold. This is an enormous cost. And while there's certainly families who choose to use ready to feed throughout the first year or so of life, it is an enormous financial outlay of funds above and beyond. So most families do use something other than what's provided in the hospital setting. Then of course you don't have those pre-sterilized nipples in their individual packs all ready to go. And let's be clear, I am no conspiracy theorist, but I understand after years of, gosh, it's gone from like catalogs to Facebook ads to now TikTok and Amazon telling me what I want to buy on Prime Day. I am a student of marketing, right, in my own life. And this is very well done marketing to families. This is really putting it out as the easiest possible alternative. And unfortunately, I think for all of us in healthcare, right, who work with families in this setting, we have also kind of been played into this narrative, right? These are the options that we have. And so is it any wonder that everybody's favorite assignment is a bottle feeding multip, right? Like this is so much easier for staff, right, Beth? I mean, this is what everybody wants. This seems so much easier, but this is not really what it's like when they go home. And this does not promote breastfeeding, right? When we're not showing the other side of the coin, which is that actually, yes, this is what we provide here for a variety of reasons, but this is when you get home, you actually will need to do X, Y, and Z. And no, there actually are some skills involved in bottling and some things to consider in terms of those choices. So this is why Baby Friendly cares about it. And also because they're an international initiative, right? So WHO focuses on all settings, developed and developing countries with and without significant resources. And in places where water is not safe, right, it's extremely important to discuss the risks of formula feeding for people who may not be able to provide clean water. Next slide. So we have our first case study, Malka and Miriam. We just love this picture, so we kept using it from the last webinar. It's a cute baby. Next slide. So we've got a lovely 42-year-old G3P2 here for a repeat C-section at 36 and 3 because, well, pre-E, it's just everywhere. I feel like it's 40% of my list on any given day. It's everywhere. It's been a stressful decade, y'all. I'm not surprised that the mom's blood pressures are high too. You look through the breast medical history, looks like she had breast cancer. She's status post a bilateral mastectomy. And she's been stable medically with respect to her oncology care, and she's excited to meet her miracle daughter that they managed to get pregnant with after a great deal of medical management after her cancer care. She has 2 sons, and she is very, very excited. And she lets the RN and L&D know as she checked in that she'll be formula feeding this time when she's asked at admission, which will be a totally new thing for me. You know, nice little intro to that conversation there. Next slide. So delivery goes great. Birth weight's a little bit low, 2,200 grams, and she feels terrible. Not surprising, Mag does that to people. And sleeps in recovery, and Dad takes over feeding. Miriam bottles 20 cc's and has what the nurse refers to as a low blood glucose measurement. And she started on Neosure 24. The nurse swaps out the milk right then and there in recovery, because explaining to Dad she needs it because of her blood sugar. Next slide. So now what? Right? I don't know about you, Beth, at a lot of hospitals, this is kind of the course we keep trucking along. Once we start on a formula, if they're tolerating it, we tend to stay with it. I have many thoughts about the selection of preemie formula here, but next slide. And she's the next couple of days, we've got a mom who's still not feeling great. She's still a mag. She's tired a lot, especially that first day, right? She's still pretty hypertensive. She's having some pain control issues, not tolerating her opioids well, so she doesn't want to take them. And she's still having a lot of pains, and she's just not doing anything but self-care at the moment. Miriam's doing okay. She completed her 24-hour BGM protocol. No issue, got cleared, it's done. She's taken 30 to 60 cc's every 3 hours. When nurses asked Dad if he has any questions about baby, he says he's got no questions about feeding. And when he's asked about feeding specifically, well, how was feeding going? Right, that's the usual question from providers and from nursing staffs. He says that she takes her bottle super well, feeds quickly, but he does admit she spits a bit. Next slide. As things usually do, by the time we get to day 4, the milk is much improved. Mag's all done. She's cursing it, but happy that she didn't have a stroke or lose her eyesight. All those good things. I think most of us can empathize, right? A lot of us can. She's on labetalol. She's taking begrudgingly a little morphine. She's told to see her OB in 5 days. In terms of Miriam, feedings are fine. She's taken pretty close to 60 cc's most feedings. She's discharged home. Miriam, baby, is discharged home, told to get seen soon, and to feed minimum 8 times in 24 hours. That's what her feeding plan is on the discharge summary. Next slide. So root cause analysis, going back, and I think the first question people are thinking is probably, well, is there anything wrong here? Actually, this is business as usual, right? Like, this kid is feeding. She's feeding what a lot of people might determine to be a pretty appropriate formula for her. She is technically preemie, right? 36 and 3, under the wire. But there's really not much discussion in the discharge summary or in anyone's notes, any of this case experience. This is a real patient, like all my cases. There really wasn't much instruction other than how frequently to feed. There was no other really commentary about how much to feed or how to feed her, mostly because things were seeming to go okay, right? Like, she was taking some volumes. That's what everyone seemed to care about, is that she was eating every 3 hours. Not a lot of discussion about why that formula was chosen, except for, well, her sugar's low. Let's go ahead and start this one. No discussion about ready to feed versus powder formula, or how to prep that formula, and what hygiene concerns there might be. So I would say there's a few things that matter here. And then because there are consequences, we're breaking the piggy bank with this kid. I usually joke when I start having this conversation with families at discharge, because this is something that I bring up with families when I discharge their infants from the hospital about formula choices for formula feeding families, is that, there's a lot of financial burden that's involved in the formula that's selected. I usually joke that their kid has already told me that they want to go to grad school and that we can't break the bank on expensive formula. The financial burden is something I think everybody, regardless of how you feel about this initiative, how you feel about lactation, how you feel about choices, or how heavy-handed we might get with feeding counseling. Like I know there are a variety of opinions, probably even on this call, and certainly on the teams you work on. But I think it's really important to recognize here that if we let business as usual go on for families, that we are probably saddling the families who do not receive WIC with a much higher bill than they need to pay. So with the exception of our baby-friendly facilities here in Georgia, everyone else receives products at a reduced rate, right, from our formula companies here in the US. And the product that they choose to provide to hospitals is typically they would describe, the reps would describe as their top of the line formula, right? Their newest, latest, greatest, this is my best product. Like, we want you to provide this. Yes, of course they do. That price point is quite a bit higher. And it's actually contractually stated typically in the contract they have with your hospital. For people who've ever done that, there's probably a few of them on the call who've had the fun of trying to find this contract deep within the bowels of a hospital or a hospital system somewhere in somebody's, online cloud. What we actually pay, is usually stipulated that the formula company selects the product. And let me tell you, they won't provide anything else other than whatever that new, latest, and greatest. And that price point per can is several dollars per can higher than some other things on their line, and certainly about 40% higher than any generic nutritionally equivalent formula that is available to a family. That is the typical price differential for a generic versus non-generic formula, is about 40%. The FDA does not let us play fast and loose with formula in this country. Things that have an evidence base for utility, medical benefit, or nutritional need have to be included in the right proportions. So I think we all have to think very long and hard about our business as usual with formula feeding families, and recognize that we are taking away from food that they will put into their own mouths, into their other children's mouths, and money that is available to pay for other needful things that will contribute to child health and success, by allowing them to take our implicit endorsement of the product that we are providing in our hospitals. There's also consequences of under or overfeeding, right? By not talking about how much we feed and how often, how that changes through time. There's some families who were kind of told, I've had families who said, well, they said that I was doing fine in the hospital when a kid is taking a ½ ounce to an ounce, and I see them at 10 to 14 days and they are skinny. And then I have the converse when I get a kid very similar to the kid in this case. And by the time I see them on day of life 8, they're taking 3 ounces. And we have to kind of have a discussion, because we have a child obesity crisis, and good bottling habits are implicated in child BMI percentile at age 5. And we need to work on this. Apologies for my pet, who's apparently taking the yes man as a serious threat worthy of barking. Apologies. We also, it doesn't happen terribly often, but it does happen that, there's illness as a possible consequence, poor hygiene. Certainly there's gastro and other infections, and we'll talk a little bit more about that in detail here in a moment, that can occur. And I think most pediatricians have had somebody with water intoxication at some point. I know I had in residency, it was a 2-month-old who passed in our ER before they ever got to the floor coated and died with a sodium of 110 after excessive solution for days, trying to make the formula stretch before they could get to WIC. The way access to care here in the metro, and gosh, probably around the state as well, I can only imagine it's worse outside the metro, works, we may not get a lot of our more vulnerable families in to get seen by a physician or a provider until 1 month of age, at which point we can do a lot of harm if we don't do this teaching. Next slide. So yes, there's consequences. I think I'm hoping that we're all kind of warming to the idea that our business as usual might have consequences for families. And again, it's like, wait, don't tell me, right? On NPR, if anyone listens to NPR, maybe I'm not the only nerd here. Where isn't not my job, right? It's somebody else's job to take care of this and do this. And as a PCP, I implore you, yes, of course it's my job. Like literally everything is my job. Literally everything to do with parenting, infant life. Like this is an infant. Let me discuss this with you. This is definitely my job too. But gosh, timeliness really matters. You guys have a captive audience for somewhere between 1 to 4 days. Please utilize it. And honestly, I have so much to do in 20 minutes. My job for some of this stuff really should be to reinforce and not teach the basics. Importantly, too, again, like if we're getting people into the office at that 2 week to 4 week mark for the first time, apologies. We really know that some infants will get habituated to fast flow really quickly. And that's a hard course to reverse with an increasingly fussy infant. We can't do that. And in general, feeding plans can be hard to shift sometimes. We see this mostly with the NICU crowd, but sometimes with the term baby crowd too. That's what they told me to do in the hospital, and I'm sticking with it. Really, your word is gold. They may not get details right sometimes after the placenta has been delivered, but they definitely listen to you. And what you say or what you don't say really does matter. So these are some of the things this is a much better behaved pet than mine here. Gosh, look at this attentive dog. These are the things that we should cover, how to feed formula hygienically, how to prep it hygienically, what types and forms of formula might be best, and this does vary by family, and how to bottle feed according to infant feeding cues, that responsive, that cue-based feeding. All right, I think I'm turning it over to Beth.
Hey, so, as we know, collaborative care is vital and important for our families. So I'm stepping in here as an NP, part of the whole team. And hygiene is really important to teach these families as we model it for them, but also what we teach for when they go home. So for families that are feeding formula, they need to know how to prepare and store formula safely. Key topics for formula safety that come from the CDC include cleaning, sanitizing, and storing of the feeding items because germs can grow quickly in a partially used bottle or in a bottle that's just rinsed and not really cleaned after it's used. The other thing that's really important to teach all of our families, whether or not they're breastfeeding, formula feeding, or partially feeding, is that they need to clean, sanitize, store everything, the baby bottles, the breast pump parts, the bottle nipples, caps, rings, valves, anything that goes in the baby's mouth, like pacifiers, teethers, because anything could have those germs that would grow on it. We need to remind the families not just to keep their hands safe, but also their surfaces safe and clean before they prepare bottles. So like countertops and sinks need to be washed. Families need to wash their hands with soap and water for at least 20 seconds before they prepare formula or before they're pulling out breast milk and using those bottles. Whatever they're doing, they need to be practicing these safety cleaning items. Families need to know they shouldn't place their feeding items directly in the sink. That's a very germy place, and so we don't want to contaminate anything by putting the used bottles in the sink. Put them on the side of the counter until you're ready to wash them. And then there are differences between the recommendations. We're going to talk about that on the next slide. But for infants, when they're 2 to 3 months of age and older, there is a difference in the recommendations on if the water needs to be boiled before the powdered formula is mixed into it for families that are using powdered infant formula. So we're just putting it out there. There's controversies, and your practice or your hospital setting is going to have to decide what they're going to use, pick something, and follow it. Question kind of goes out to you guys. What do you normally teach about formula for families, and how are you going to modify that after today? So here's a comparison chart just so that you guys can see. There are definitely mixed messages. Like we are not saying they're not, and we don't have the answer. There is not an answer. So again, pick something, stick with it. But if we kind of compare the messaging across the manufacturing companies, national recommendations, international sources, there's an inconsistency. WHO recommendations includes a rationale for why a family would want to either use ready to feed or go through all the extra steps of boiling water prior to mixing the powdered formula in. And then if you look at the CDC recommendation, that's going to include specifics about which infants are considered the most at risk, therefore necessitating all those extra steps. Hopefully this combination is helpful as an education source, which would sort of look like the correct preparation and handling reduces the risk of illness. When available, commercially sterile, ready-to-feed liquid infant formula should be used for infants at greatest risks. Infants at greatest risk are those that are less than 3 months of age, those born prematurely, and those with a compromised immune system. Reconstituted powdered infant formula provides an ideal environment for the growth of harmful bacteria. So even if it's present in that powdered formula at very low levels, inappropriate preparation and handling of the feeds will provide an ideal condition for the growth of that harmful bacteria. This will greatly increase the risk of infection for those high-risk infants. Therefore, we can reduce the risk if we prepare the feeds and handle the feedings correctly. Why do we care? Big word is Coronabacter. So, why are we obsessing about formula preparation? Coronabacter is a germ. It's found naturally in the environment. It can live in dry foods, such as powdered infant formula. It can be in powdered milk, herbals, teas, starches. It can also live on surfaces, like kitchen countertops or sinks. And it can live in water. Sneaky little germ here. Powdered infant formula can be contaminated at home or in the processing facility. Coronabacter can get into the powdered infant formula in the processing facility if the manufacturer uses contaminated ingredients to make the formula, or if the powdered formula touches a contaminated surface. At home, Coronabacter can accidentally get into the formula after the container is opened. So, at home, if the formula lid or scoop is placed on a contaminated surface like a countertop, it can later contaminate the formula it touches. Alternately, you could accidentally get Coronabacter if you mix the formula with contaminated water or in a contaminated bottle. So we have all sorts of different layers where this germ could be introduced into our formula. While Coronabacter infections are rare, they can be life-threatening in newborns. Infections in newborns typically occur in the first few days or weeks of life. Coronabacter can cause sepsis or meningitis. Infants at most risk are those that are younger than 2 months, who are born prematurely, or those with weakened immune systems. Symptoms look like fever, poor feeding, excessive crying, or very low energy. Some might have seizures. So any young infant with any of those symptoms should be brought to a medical provider as soon as possible. So what if boiling is not really an option? There is ready to feed. We're going to kind of go over the WIC part for the families that qualify and for the places that serve those families. WIC does not routinely provide ready-to-feed formula. However, it is available for WIC for eligible families when a medical provider determines and documents any of the following things. So, if the participant's household has an unsanitary or restricted water supply or poor refrigeration. If the person caring for the participant has difficulty in correctly diluting or the concentrated or powdered form of formula. If the particular formula is only available and ready to feed. If the issuance of nurse sets are like those little tiny individual ones is more appropriate than a larger container of ready to feed, like there's like liter containers. And then additionally, WIC will issue ready-to-feed formulas to participants with qualifying medical conditions if they are assigned a food package 3 and prescribed a special formula. So the ready-to-feed, if the ready-to-feed form better accommodates the particular participant's medical condition, or if it improves the participant's compliance in consuming the provided recommended formula. So if we go back to our case study, what do we need to tell this family? For the people that are feeding Miriam, what should we teach them? In most hospital settings, we're going to use the ready to feed. So the mixing of powdered formula is not often modeled for families. Prior to discharge, we need to review the need to heat the water, mix the formula into the water while it's still hot, cool the formula mixture, and then either feed or refrigerate it and use it all within 24 hours. Or we need to encourage Miriam's family to use that ready to feed while she is a high-risk infant. Even as a healthy newborn who is in the well baby nursery, we need to teach Miriam's family that she is high risk for the first 2 to 3 months of her life, and they'll need to take these additional steps for her safety when they're making her feeds. When we talk about formula choice with her family, we can help educate. Next slide. The FDA's nutritional specifications for infant formulas are set at levels to meet the nutritional needs of all infants, and formula manufacturers generally set the nutrient levels above the FDA minimum requirements. So babies that are fed infant formulas don't need extra nutrients unless they're fed a low iron formula. The infant formulas that are available in the US are either labeled like infant formula with iron, or additional iron may be necessary. The American Academy of Peds recommends that formula fed infants receive the infant formula with iron one. For families that have questions about name brands versus generic, educate them to look at the nutritional content and let them know that, the FDA guidelines are standard. Infant formula manufacturers might have their own proprietary formulas, but everything has to contain the minimum levels of all the nutrients that are specified in the FDA regulations without going over the maximum levels, if there's a specific maximum level specified. So, and then when it comes to generics, in the US, all the generic brands are made by the same manufacturing company. So again, when we go back to Miriam and Malka, what could we teach this family? Next slide.
And I want to just throw in just really quickly, Beth, sorry, that, the companies will, put out their own kind of advertising and discussion of studies that show that this and this and this occurs. I don't know that those hold to the burden of evidence that's really necessary. And again, the FDA does provide oversight. If there was a need to include their special gentle proteins, I think we would be including those probably across the board. I just would like to just throw that out there, that we should be cautious of the line between science and marketing, and that families may
Excellent
not
point.
be able to distinguish between the two.
Excellent point. Thank you. So when we go back to Miriam's family here, what do we need to teach her? They need to know Miriam doesn't need this preemie formula long term. When can she safely wean off of it, and how do they do that? They need to know that they can safely purchase any brand of formula that's available to them. Available might be at that particular cost point, like Dr. Fairley was mentioning. It also might be what they're able to find where they live. Like, does their normal place they shop make this brand and have this label that's this color? And would getting to a store that made this other brand that's this label and has this color on it involve hours of driving? And is that not feasible for this family? So what can they actually find? That's important to consider and to talk to this family about. If they are buying powdered formula, they need to know to mix it according to the high-risk infant recommendations, which I don't think many families would consider their healthy term newborn to be high risk. So making sure they know to follow those recommendations for the first few months of this baby's life. Um, and then we're also going to recommend that that this family would feed Miriam in a paced bottle feeding manner on cue. So when she tells us that she's hungry, we're going to feed her in a manner that works for her, which we're going to talk about on the next slide. And then we also need to discuss how much to feed her, which is going to be in a minute. So the next thing we're going to teach them is pace bottle feeding. So pace bottle feeding is an important feeding method for all parents or caregivers that are feeding any infant via bottle. With pace bottle feeding, the baby has control over the speed of the feed. And what that means is that the milk flows from the bottle into the bottle nipple and subsequently into the baby at a slower speed than if they're being held like in a more way that you would traditionally seen a baby held in the crook of the parent's arm with the bottle like this. So the speed is based on what the baby needs in the moment. Are they able to tolerate more at this time, or would they like the flow to slow down? The feeding person determines this based on the infant's cues. What does their face look like? Are they moving their mouth, or are they taking a pause? When they need it, a slowdown in the feeding volume allows the baby to take breaks or fully stop when they're full, if they need to coordinate their breathe, suck, and swallow, or if they need to catch their breath. And pace bottle feeding reduces the risk of overfeeding. It helps infants or young children to eat appropriate volumes and to volumes or quantities to fulfill their hunger, but also recognize their satiety. So there's a whole micro lesson on paced feeding if you'd like more information on this or to see some video demonstrations. And then I'm going to hand it back to Dr. Fairley for the next section.
Right. All right. So bottle and nipple selection. It's not like a no man's land without data, but there's less data than we'd probably love to have, mostly because things are not super standardized in the market. And I talk about this a lot with families, just how much flow rates vary so widely. And then, each bottle they're very similar classes, but some babies do much better with one that's compression as opposed to relying on a vacuum seal, depending on kind of the tongue and the anatomy and the infant's mouth shape. So it can be really challenging. I mean, just look at all this. This is just a small selection of what's out on the market there. So this is quite challenging. It's also challenging that people tend to register for these things well before delivery and have things at home. And it can be hard to correct that course because that often represents an outlay in funds. My general guidance to be more inclusive for people who already have products at home they wish to utilize is to utilize, especially in those first 3 months, although I rarely switch people off of it. That's a whole combo for another day, but I could talk about how infants get more efficient with their bottling practices over time all day long. I usually recommend a preemie or a newborn nipple for whatever bottle system the family has at home. And if feeds take too long with that preemie or newborn nipple, not to necessarily go up on the flow, I'm going to throw in a nota bene that I am not a peds occupational therapist or speech therapist. And so this is the general pediatrician's take. But in general, in my experience, if feeds take too long, that we try another style or shape of nipple, not necessarily a faster flow. So for the kids who are having trouble, say a Dr. Brown's, which does really rely on a baby maintaining a vacuum seal to the nipple, we'll often switch to a MAM 0, which is their newborn preemie slowest flow there on the market, which is compression based, and those infants will usually feed much better. So we don't necessarily go up and flow for these very young babies. And pacing is always needed. I could talk about pacing all day. I'll stop. There's a micro lesson. That's why we have it, right, Beth? Anyway. But pacing is so much more manageable if you have the right nipple in hand. I have a hard time with the default yellow nipples in the hospital sometimes with pacing, and I think I'm pretty good at it. Next slide. So this is a nice chart from some of the few articles out there that are kind of out there in the literature on the different nipple flow rates. And you can see that they kind of vary widely. We've got the Dr. Brown's Ultra Preemie. Who even knew that was a thing, Beth? I've used it on like 2 patients now. It's slow. It's great. That gives you 4.2 mLs per minute. And then you've got, the NUK first choice size 1, by the way, and it's faster than some of the others out there, right? The standard T, you'd think that would be pretty fast. No, that's actually 13. The NUK size 1 is actually 31 cc's a minute. That seems really fast. Anyone else? Maybe I don't drink enough of a bolus myself and I should think about things. But that seems like an awful lot to gulp down in a minute's time. Right, exactly. So they vary widely. And so the usual guidance to try and get, for whatever brand you have, the slowest pace, and then just switch shapes if it's still too fast or they're not having an easy time feeding. That's where this is born out of. But we'd like a little bit more standardization in the market. Next slide. God, volumes. So it's a slippery slope, right? I think I've talked about this before. We talked about supplementation and kids who needed medically indicated supplementation in the hospital and not wanting to overdo, because then you have families going home taking 8 cc's every 3 hours. And then the baby is underweight at the first pediatrician's visit. Like, I get that there's concerns. So we don't want to overly limit. But at the same time, physiology is physiology, and I have a hard time ignoring it too much. So smaller volumes over those first few days are really normal. And then probably closer to 1 ounce Q3 hours is probably typical by day of life 5. And obviously things are weight-based, and I hear you. But somewhere in that neighborhood, and I certainly don't think our little Miriam here in the beginning was taking an appropriate volume, 60 cc's Q3 on day of life 4. It gives me a bit of angina, really. So I think we can all agree that while we worry about overly limiting babies and what that looks like going forward, we still probably need to provide some type of guidance. And where this shakes out, yes, and Linda, you agree, it's very challenging. You don't want to do any harm, but at the same time, having no discussion about things is also really challenging, especially for a family like this one. This family is very deliberately chosen because I think this is very clear, right? We've had a mastectomy. We're not going to be breastfeeding. I think it's quite the clear conversation. But they also have no subject matter. She's a multip here, but she has no idea what she's doing with formula feeding. We really should have given some guidance. She never measured anything before. She just put the kid on the breast. Next slide. So when do infants take more? Again, this could be a whole other talk. We have our highest growth needs. Here in this first 6 weeks of life, we'll need less by 6 months. I can't remember which one, the 82 is from Harriet Lane or the 76 is from Harriet Lane, but by 6 months of age, we end up dropping, and I found the 76 in one of my other textbooks that I still have on my shelf, as I feel very antiquated saying I still have books around my house in general. And these volumes of, yeah, no, I agree, Linda. Even the multips don't do pace bottle feedings. Yep, I hear you. We have a lot to work on in this sphere too, right, with feeding. So you do increase volumes of feed. The volumes of feedings do increase over time, but they're also supposed to be sleeping longer stretches overnight. And so we're supposed to be getting a relatively similar volume in 24 hours, but simply kind of spaced out a bit differently because we've got those longer overnight stretches of sleep that I've heard some children do. No one I took home from the hospital, but I've heard some children do that. Yeah, Beth is also nodding no. We're team no sleep over here. And so when we counsel families that, babies do take more, of course they take more. Oh, he's almost 6. I hear my colleagues say these things like, oh, he's almost 6 months. Of course he's taking 8 to 10 ounces. Well, I'm sure he can take 8 to 10 ounces. So there's a lot of behavioral considerations too, right? They can more avidly empty a bottle. They're much more able to do so. It doesn't mean that they need to take down 10 ounces every 4 hours, so that's nutritionally valid when their growth needs have actually decreased. So lots of discussion here. We cover some of this on our Georgia AAP. We've got some on-demand webinars, and I think our daycare talk kind of goes through some of this. The daycare and return to work and supporting families talks about this in a little bit more detail, but I do feel like thinking about volumes, especially as children get older, is a lost opportunity for pediatrics in terms of child obesity prevention, and it's something that needs to shift. But I'll move on. Sorry. Next slide. So this is kind of the rough idea of what we should tell her. About an ounce every 3 hours by day of life 5, and she'll eventually get up to that 2 to 2.5. She's will eventually take larger boluses, but like she's not likely to do so now. Her stomach's not that big, right? I tell them to watch for feeding cues. I usually show them a QR code for a pace feeding video, tell them that feed should take a while. It's not how I eat my lunch over my desk while charting, shotgunning down my food in 5 minutes. It's not really what we want to model for our children. We want them to eat lunch with a friend, right? And take slower feedings. And then to use a Premier newborn nipple until much older, or talk to your pediatrician. So what would our best case scenario? What would that look like? So when we go to L&D, she tells the nurse that she's excited to be she's going to be formula feeding. This is kind of new for me. And she mentions that we'll show you or dad how to feed her after delivery. No worries. Next slide. So delivery goes great. And again, she's 2,200 grams. And in this case, nicely, just putting in a little bit of it. We would call this an Easter egg. We'll call it a nice hint of things to come. Bath is delayed for this 2,200 gram baby. To prevent this hypoglycemia that we're a little bit worried about. I guess it helps some, right? Her blood glucose here is 35. The nurse explains the protocol that we'll be checking her blood glucoses because she's preemie and because she's 2,200 grams. And importantly, in recovery, mom doesn't feel well and she's sleeping, won't go sleeping, but dad is helped with the friendly nurse to do some skin-to-skin care, which is important for all babies. And Miriam bottles 10 cc's with a slow flow nipple. So postpartum still sucks because nothing about the best case scenario means that we can change that because it still sucks. Yep, sure does. So, Malka's still having a hard time with things. But Miriam's doing pretty well, 15 to 20 cc's every 3 hours, green nipple. As she goes along, she's getting a little bit more volume each time. She's doing well, nice and slow. Every shift, nurses kind of review with dad how to pace feed. They observe a feeding. Reassures dad about some of the spitting that she's doing and talks about how pacing can help and kind of tweaks pacing here and there when he mentions the spitting. And they do ask about bottles at home and mentions, hey, you're going to want slow flow nipples for this baby. You might as well get a Premier or a newborn nipple. Maybe see if you registered for those. It's a good dad task, right? Look on Amazon. Next slide. So in terms of discharge planning, she's still told to follow up with OB in 5 days, and Miriam's done pretty well, almost always taking 30 cc's, most feedings, does well with the green nipple, and dad's really learned a few things, and it's kind of a whiz. Malka now fails behind the 8 ball because dad paces really well. Apparently he's taken over this job. Discharged home and told to get the baby seen soon and to feed at least 8 times in 24 hours. That never changes. That's standard on all my forms too. But the formula prep gets reviewed with them. They are given the CDC sheet on formula prep and told if they're not able to boil to prep the formula, like overnight, you're too tired, it's good to have a stash ready to feed around to use because otherwise it's not safe. And then the provider actually has the formula choice discussion with the family, talks about how it's not necessary to use the hospital brand, that Miriam wants to go to grad school, and that generic formula is fine as long as it's hygienically prepared and used and mixed according to the proportions on the back of the can. So what went well here in this best case scenario, right? Well, we did kind of help the poor small baby out, right, by not letting her get too cold. I think that part is nice, and we'll talk a little bit more about this, like I said, in an upcoming webinar. Our hypoglycemia management was a little bit enhanced and normalized, right? Like infants are hypoglycemic the first 24 hours, especially those with risk factors. It's nice not to pathologize and pick a preemie formula, perhaps, if we have other options. Says the general pediatrician, I'm willing to hear dissenting opinions. Skin to skin care was provided, important for all babies, great for development. It's great that it was provided here. And again, part of our hypoglycemia management that got enhanced. And importantly, Miriam was taking much more appropriate volumes at DC. the formula choice for this family. We talk a lot about feeding choices, and this is something that gets bandied about a lot of times, and what I have, after 18 years, learned to call the lactation wars, right? Like, this is something that's feeding choices. We're not respecting people's feeding choices. Well, also the milk that they provide is also a choice, and we need to set this up very firmly as something that they get to choose, and do not take what we're providing as an implicit endorsement. This is simply what we have on stock available for you to feed your infant. Medically, I think your baby can feed X, Y, and Z, and then we counsel. That is informed consent and a full choice for these families. And not least at all, formula preparation hygiene was also discussed. So I've seen a little bit of chatter, and I've gotten distracted occasionally during the webinar with some of the chatter, but I'm very happy to hear thoughts, what business as usual looks like on your floors. Ideas. I think Linda said that the multips don't do any paste bottle feeding or have any idea of volume. Agreed. I think people also forget the very early days with an infant as well. So, other thoughts, Beth? Comments?
I think families have to forget the first few days with an infant. Otherwise, no one would have more than one child, and you and I wouldn't have jobs. So,
Correct.
I mean, I get it.
We would be a world of only children, yes, if
Exactly, and
there
no
was
good.
not postpartum amnesia.
Yeah.
Yes.
So
Yes.
I feel
No
like
good
there's a
can come of
purpose
it.
in that.
For sure. People do forget. 100%. Yeah, so I think. So Joshua, you had a comment about Similac product, with which I am not super familiar, so I'd love to hear more. Well, Claire, any other people? Yep. Yes, I heard a great talk about HMOs. Okay, well, be happy to chat with you offline about that. We'll share with Claire or you. Thank you. Great. So our big take-home points here, just, we need to make sure that families understand that formula feeding isn't the default easy norm in the community, right? It's not. Like, there's nothing about feeding and caring for babies that's easy. Let's be very clear. Nothing. All of it requires a good deal of investment of work and labor. Oh, no, Mike. Oh, sorry, Dr. Joshua. And then not providing instruction on formula use sets up a false narrative with respect to lactation for staff, right? As well as for families. Safety is always a concern, especially with some of the more recent issues, recalls and other things. So let's address process here and keep people safer. And then please, from the pediatrician in the trenches, pace feeding is really for all babies. Let's see if we can teach on it. Next slide. You guys have been fun.
Thanks so much, Dr. Fairley and Beth. That was really excellent. We do have a couple minutes if folks have any additional questions, and I have a couple of more dates I want to make sure we share. It's kind of our standard. If you haven't completed your September audit, please make sure you do submit that. If you have any questions about it, you can always reach out to Linda. Her email is listed there on the slide. The October audit will be out the 24th, and then we will be having a November webinar, our second Tuesday, as always, on November 14th. So we look forward to seeing you there. And finally, make sure that you log your attendance for this webinar so that we know you attended. You get that credit. And I can put the link in the chat as well. You can't use that QR code. There's no final questions. Thank you, everybody. Have a great afternoon.